Hello everyone. I have already covered up to the GIT examination in newborn. Today I am going to tell you the details of respiratory system examination. And RS examination always start from the examination of nose. Then we have to perform the inspection, palpation, percussion, auscultation. Then examine the nose for its shape, position. Check the nasal bridge, nasal septum, columella nasi, ali nasi, nares and nasal cavity. In nose examination, we should insert the nasogastric feeding tube in both the nasal cavity to rule out the choanal atresia. If baby is having bilateral choanal atresia, then baby will become symptomatic having the central cyanosis with the respiratory distress. And this cyanosis resolve during crying. While in the cyanotic congenital heart disease, patient will have the exaggerated or worsened cyanosis during the crying. So we can clinically also differentiate. This condition requires the urgent intervention. After nose inspection, we have to check the shape of chest is normal or not. Then see the symmetry bilaterally present or having any asymmetry. Then check the position of nipple and breast. Then see the movements of chest bilaterally equal or not. Then check any signs of respiratory distress. Example, baby is having the tachypnea, nasal flaring, retractions, grunting sound, cyanosis. Then we have to mention. After that, check for any pulsating vessels or distended chest veins are visible. Then see any scar or mass visible. In newborn, normal shape of chest is near round. Here in this image you can see in term baby shape of chest is near to round. Slowly as the baby grows it becomes elliptical. If baby is having any pathology, then abnormal shape of chest can be there. Example, pectus excavatum when there is depression in sternum. Pectus carinatum when there is a prominence of sternum. If baby is having the tension pneumothorax on one side, then bulging can be there. So we have to mention the abnormal shape if it is visible. Then check the symmetry. Bilaterally chest is symmetrical or not. If any asymmetry is there, example in tension pneumothorax, there will be prominence of one side of the chest can be there. Asymmetry can also be due to absence of pectoralis muscle. It is a rare condition, and also we have to check the shoulders. Any shoulder drooping is there or any depression is there. So any asymmetry because of bulging, depression, then we have to mention. Then we have to check the position of nipple and breast. If both the nipples are at the same level and normal position, then we have to mention. If any abnormal finding is there in the nipple or breast, then we have to mention. Example, in this image you can see baby is having the mastitis neonatal. So you can see the swelling of the breast is visible. After that, in movements of the chest, we have to mention the respiratory rate. Normal rate in newborn is 40 to 60 per minute. We have to calculate the chest rise in full 1 minute. If baby is having apnea, bradypnea or tachypnea, then we have to mention. Then check the rhythm. Rhythm is normal, regular, or baby is having any abnormal rhythm. In normal regular rhythm, inspiration is longer than expiration and there is a no pause between inspiration and expiration. Periodic breathing is also the normal variant of the rhythm in which baby will have the normal breathing for 20 or more than 20 seconds. Then it is followed by the respiratory pause for 3 or more than 3 seconds. And again it is followed by the normal breathing. It is normally seen in the preterm baby and also during the sleep in full term baby. If baby is having any abnormal rhythm, example Chinese frog breathing, Biot's breathing, paradoxical breathing, then we have to mention. In Chinese Stork's breathing, baby is having the gradual hyperapnea. Again, there is a gradual hypoapnea, then followed by apnea. And in Biot's breathing, baby is having the hyperapnea. You can see in this image hyperapnea, then again it is followed by apnea, again hyperapnea, then apnea. Both Chinese stroke and Biot's breathing seen whenever there is a raised ICT because of CNS lesion or CNS pathology or infections. While in the paradoxical breathing, here in this video you can see inward movement of the chest occur during the inspiration. So during inspiration in normal rhythm, outward movement of the chest occur. While in the paradoxical breathing, inward movement of the chest occur. So here in this video you can see it is paradoxical breathing. So these are the abnormal rhythms. Then we have to check the signs of respiratory distress are present or not. Check for the respiratory rate. If the baby is having more than 60 per minute, means baby is having tachypnea. Then check for the nasal flaring and any audible grunting sound is there or not. And then check for the retraction and central cyanosis. So in this video you can see baby is having the severe respiratory distress. Audible grunting sound is also there. Severity of respiratory distress according to the Silverman-Anderson score in preterm's baby and according to Downey's score in the term baby. In Silverman-Anderson scores, we have to give the score between 0 to 2 for all these 5 parameters. Upper chest retraction, whenever there is a synchronized respiration, we give the 0 score. When there is a leg on inspiration, 1, and seesaw breathing, we give the 2 score. Lower chest retraction, gyphoid retraction, and for the nasal flaring, if no retraction, then 0. Just visible or minimal, then 1. And when there is a marked lower chest retraction, gyphoid and nasal flaring, we will give the 2 scores. And for grunting, if not audible, 0, audible with the state 1, and audible with the naked ear, then 2. So here in this video you can see baby is having the leg on inspiration present over here for the upper chest retraction, and for lower chest gyphoid and nasal flaring baby is having the marked. So 2 score for these 3. And for grunting it is audible with the naked ear. So again 2. So total score 9. 2 plus 2 plus 2 plus 2, 8 plus 1. So baby is having severe respiratory distress. Now the severity according to the Downey's score. For the full term baby, we have to give the score between 0 to 2. For respiratory rate, if it is normal between 40 to 60, 0. Between 60 to 80, 1 score. More than 80, severe, 2 score. When patient is having no cyanosis, then 0. If patient is having the central cyanosis, even on room air, we label as a 1. More than 40% oxygen is already given to the patient, still the patient is having the central cyanosis, then 2 score. Air entry normal, 0 score. Mildly decrease, 1. Marked decrease, 2 score. When there is no retraction, 0. Minimal retraction, 1. Marked retraction, 2. When no grunting sound, 0. When audible with the stethoscope, 1. When audible with the naked ear, then 2 score. Observe this baby and calculate the Downey's scores. So you can hear the audible grunting sound. You can see the marked retractions are there. And respiratory rate between 60 to 80 per minute. So score for the RR 1. Patient is not having any cyanosis. So we will give the 0 score. Air entry mildly decrease. So 1 score. Retractions are marked. Patient is having seesaw respiration and paradoxical breathing, audible grunting sound. So patient is having total score according to the Downey's 6. So patient is having Severe respiratory distress. After assessing the distress, we should see any visible pulsating vessels or distended chest vein over the chest area, any scar, mass or lesion over the chest area. So in this image you can see baby is having the large lesion over the chest because of the ruptured bully. After inspection, we should perform the palpation in which we have to localize the apex beat. We should palpate for the movement of the chest wall and palpation for any adventitious sound, any palpable rhonchi, rub, crepitations, and then we have to palpate for vocal fremitus. Now to localize the apex beat, we should remember it is the lowermost and outermost point in the precordium where the definite cardiac impulse is felt. Normally in newborn it is felt half to 1 centimeter inside the left midclavicular line in the fifth space. It can be shifted to the same or opposite side if patient is having any cardiac pathology. We should use our palm of the hand to feel the apex beat, and localization of the apex beat should be done with the single digit. For the movements of the chest wall, comparative palpation of the two sides of the chest for evaluation of the symmetry of the expansion of chest wall should be done. So we should use both the hand. I have already explained how to palpate the chest for the movements in one of my video on respiratory system examination. Now for the vocal fremitus in newborn, we have to palpate the vibration of the chest wall when baby is crying. We have to feel when baby is crying. So we should use the medial side of the hand and we should check both the sides simultaneously. Increase VF seen when patient is having consolidation and decrease VF if having the pneumothorax, pleural effusion, any pleural pathology, and also in collapse, fibrosis, bronchial obstruction. We should also palpate for any palpable rhonchi, rub or crepitation. Palpable crepitation can be present because of the subcutaneous emphysema also. There is no role of percussion in respiratory system examination in newborn. Then we should auscultate all the anatomical areas of the lung for the breath sounds to see normal or abnormal. Check for any adventitious sound if it is audible and check for the vocal resonance. Breath sounds are audible because of the flow of air in the lungs. We should check the pitch of the sound, intensity of the breath sound and quality of the breath sound. And we should also check both lung field are having the equal intensity of the breath sound or not. There are three types of the breath sounds: vesicular, bronchovesicular and bronchial. Vesicular breath sound is the normal breath sound. It is soft, low pitch sound heard over the healthy lung field. In this, inspiratory phase lasts longer than the expiratory phase. So you can see this is inspiration and this is expiratory phase. So inspiration is longer and also intensity of the inspiration is greater than the expiratory sound. And there is no pause between inspiration and expiration. It is the characteristic of vesicular breath sound. Bronchovesicular breath sound, mid-range pitch and intensity sound. In this, inspiration and expiration both are almost equal in intensity and duration. There is no pause between inspiration and expiration. Bronchial breath sound is loud, hollow and high pitch sound. Here in expiratory phase either equal or longer than the inspiratory phase. And there is a pause between inspiration and expiration because of the absent alveolar phase. Patient example in consolidation, fluid is collected in the alveoli, so alveolar phase is absent. Bronchial sound normally can be heard over the trachea. When you will keep the stethoscope over the trachea, The quality of the breath sound which is audible over the trachea is bronchial sound. If it is heard other area of the lung, bronchial sound is always abnormal. So in the lung field, bronchial sound is always abnormal. There are three subtypes of the bronchial sounds. Bronchial breath sounds, tubular, cavernous and amphoric. Tubular seen in the consolidation and better heard with the diaphragm of a stethoscope. Cavernous seen in the lung cavities. It is better heard with the valve of the stethoscope. Amphoric breath sounds in hydropneumothorax and large pulmonary cavity with the patent bronchus. It is of metallic quality sound. So this table is showing the difference between vesicular and bronchial breath sound. Vesicular always normal. It can be normal over the larynx and trachea. In lung field, it is always abnormal. It is heard all over the chest except over the larynx trachea, because over the larynx and trachea, breath sound quality is bronchial. Rustling and breezy quality of the vesicular sound and blowing quality of the bronchial breath sound. It is soft, low pitch. It is loud, high pitch, hollow. Inspiration longer than expiration. Both are equal or expiratory phase is longer than inspiration. No pause, there is a pause between both inspiration and expiration. Then we have to check the breath sound intensity. So these are the score for the breath sound intensity. We have to give the score between 0 to 4. We have to compare the intensity on both sides of the chest and air entry is adequate and equal bilaterally or not. We give the 0 grading when there is a absent breath sound, 1 when barely audible breath sound, 2 when diminished breath sound, 3 normal breath sound and bilaterally equal audible, 4 when louder than the normal breath sound. So we have to compare the intensity by this BSI score in both the lung fields. After that, we have to auscultate for any abnormal respiratory sound labeled as adventitious sound. It is categorized into two types, continuous and interrupted sound. Continuous sound lasts more than half of the respiratory cycle, while the interrupted sound, it is a brief burst, just like popping of bubbles. So example of continuous sound, wheezes and rhonchi, and example of interrupted sound, crackles or rails or crepitations. So these are the various additional or adventitious sound: Stertor, Stridor, rhonchi, wheezes, crackles, grunting and rub. I am going to tell you the details of all these sounds one by one. We can differentiate the adventitious sounds on the basis of site of production, either at the level of nose, pharynx or from the larynx or trachea or in bronchus, bronchi or bronchioles or in alveoli. Then see the timing in respiratory cycle, either during inspiration or expiration or in both. Then see, is it low pitch or high pitch sound? Then see the intensity, loudness of the sound, and then check the quality of sound. Is it the musical or having other quality, metallic quality? So what is the quality of sound? So first is Stertor. This sound is produced because of the partial obstruction at the level of nose and pharynx. So it can be during inspiration or expiration or in both. It is mid-pitch monophonic sound. It is loud sound. Even with the stethoscope, it is loudest when you will keep the steth near the mouth and nose. It is also considered as a snoring sound because of partial upper airway obstruction. There are various causes of stertor. Partial obstruction at the level of nasopharynx, oropharynx, hypopharynx can lead to this. So example in newborn, choanal atresia, and stenosis can lead to this sound. At the level of oropharynx, micrognathia or having the macroglossia, and in children's because of the adenoid and tonsil hypertrophy, patient may have the stertor sound. At hypopharynx, when tongue-based mass or patient is having pharyngomalacia. Even the simple nasal congestion and secretion can produce the sound which is audible without a stethoscope, and it is also associated with the intermittent sneezing. In newborn, intermittent sneezing is not considered as a URI because it is a normal and physiological phenomena in first few days after birth. Now after starter, second sound is I'm going to describe is stridor. It is at the level of obstruction at the level of larynx and trachea. So whenever patient is having laryngitis, laryngomalacia, or having any mass at the level of larynx or trachea which is obstructing this, then patient can have the stridor. Stridor is due to partial obstruction of laryngotracheal airway, and it is harsh, grating sound. It is also monophonic, high-pitched sound. It can be due to during inspiration if obstruction is at the level of subglottis, and biphasic both during inspiration and expiration if obstruction at the level of glottis or subglottic area, and expiratory stridor sound whenever obstruction in the lower trachea. Now here stridor sound. So you can see in this video this suprasternal retraction visible, and this sound which is audible is stridor sound. So patient is having suprasternal tug, suprasternal retraction with stridor, and also had the intercostal recession. Whenever newborn is having the stridor with the respiratory distress, that means it is because of the narrowing and obstruction of the larynx and trachea. Example, it can be seen whenever patient is having vocal cord paralysis, subglottic stenosis, vascular ring, papillomatosis, any foreign body, and this worsen during the crying. So, or it can be because of when we extubate the patient from ventilator, then partial obstruction at the level of larynx can lead to this. Stridor with no respiratory distress in newborn period or in infant can be because of tracheolaryngomalacia. It is a benign condition and resolve spontaneously by the time of baby is 1 to 2 years of age. Now wheeze and rhonchi. These sound produced because of obstruction at the level of bronchi and bronchioles. So whenever patient is having narrowing of this lower airway, this sound can be produced. It is mainly during the expiration but can be occur in the inspiration and expiration both, but do not occur in inspiration alone. And quality just like whistling and musical sound, and high pitch sound, polyphonic sound. Basic difference between wheeze and rhonchi is uh, difference of pitch and the site of production. Both are because of the airflow through the narrow airway. Whenever airway is narrow, this sound will be produced. Wheeze is high pitch sound, musical sound, and caused by the constriction of bronchioles, while the rhonchi is low pitch and coarse sound, loud sound compared to the wheeze, and it is because of the obstruction of bronchus and bronchi obstruction, and sometimes even the tracheal obstruction can produce a rhonchi sound, but mainly at the level of bronchus and bronchi, while the wheeze because of obstruction of bronchioles. Now here, this is wheeze and bronchi sound. Then grunting sound. It is a low and mid-pitch sound audible during the expiratory phase, and it is caused by the sudden closure of glottis during expiration in an attempt to increase the airway pressure and lung volume and to prevent the alveolar atelectasis. It is characteristically seen in the preterm newborns, those who are suffering from respiratory distress syndrome due to surfactant deficiency. In this video, grunting sound is audible. Newborn is suffering from respiratory distress syndrome. Now lastly, adventitious sound which I am going to describe is crepitations, or we can say crackles or rails. These are either coarse crepitation whenever secretion is collected in the bronchi. This sound is produced because air passes through the secretion in the bronchi, and also because of the sudden opening of the stiff alveoli or fluid collected alveoli, while the fine crepitation produced because of the fluid collected in the alveoli. Both coarse and fine crepitation seen in the consolidation, coarse crepitation in the late stage of the consolidation, while the fine crepitation in early stage of the consolidation. Fine crepitations are short and sharp. It sounds like rubbing of hair between fingers, audible during the late inspiration, while the coarse crepitation louder and longer compared to the fine crepitation, and it resembles the cracking sound produced by the fire. Coarse crepitation also seen in the bronchiectasis and lung abscess, and fine crepitation also seen with the left ventricular failure. But in children, coarse crepitation are easily audible and characteristically seen audible in the pneumonia. Now here, coarse crepitations. It resembles like bubbling sound also. After that, we should auscultate for the vocal resonance. It is a sound which is heard with the stethoscope over the chest during crying, and this sound increase in consolidation and decrease in pleural effusion and pneumothorax. So this is all about the respiratory system examination in newborn. Thank you so much.